Okay, I'm just going to give it a couple seconds as people start to flow in. All right. So for the sake of time, I'm going to get started. Hello and welcome to our webinar, Supporting Perinatal Mental Health During COVID-19. During this webinar, our speakers will share the latest research on the impact of COVID-19 on postpartum mental health in Ontario and will describe barriers to and facilitators of access to postpartum mental health supports during the pandemic. My name is Cassidy Gardner. I am a Policy and Program Officer at the Ontario Public Health Association. Before we begin, I'd like to take a moment to acknowledge the land on which we are working and the traditional people of this land. I am currently working in Toronto, and I would like to acknowledge that this is the land of the Anishinaabe and the Haudenosaunee, the Wendat, and the Mississauga of New Credit First Nation. We recognize that Indigenous practices of health and well-being have been in place on this territory for thousands of years and are maintained to this day. As a settler, I am grateful to have the opportunity to work on this land. For those that are joining us today that are new to OPHA, I'd like to share a brief mention of who we are. OPHA is a member-driven, nonpartisan, charitable organization, and we focus on providing leadership around issues affecting the public's health and strengthening the impact of those that are active in public and community health throughout Ontario. If you would like to stay up to date on our work, please sign up for our e-bulletin on our website. If you would like to get more involved in our initiatives, such as our advocacy efforts, we also have the option to join as an OPHA member. I am pleased to welcome Hilary Brown, who will be moderating our webinar today. Hilary is the co-chair of the Ontario Public Health Association Reproductive Health Work Group. She is an assistant professor at the University of Toronto and an adjunct scientist at the Women's College Hospital and the Institute for Clinical Evaluation Sciences. And now I will pass things over to Hilary to introduce our speakers.
Thanks very much, Cassidy, for the introduction, and thank you everyone for being here. We're really pleased to be able to offer you this webinar in supporting perinatal mental health during COVID. I'll note that this is the first in a series of webinars that we'll be hosting on COVID and reproductive health, so please do stay tuned for information on upcoming webinars. And with that, I would like to introduce our first speaker, Dr. Simone Vigod. Dr. Vigod is a professor of psychiatry in the Teambased Faculty of Medicine at the University of Toronto, head of the Department of Psychiatry and Shirley A. Brown Memorial Chair in Women's Mental Health Research at Women's College Hospital, and senior adjunct scientist at ICES. Her program of research focuses on the improvement of mental health of pregnant and postpartum people, along with the health and developmental trajectories of their children through large-scale population-based epidemiological research and randomized controlled trials of innovative treatments and health system interventions. So thank you very much, and I'll turn it over to you.
Thank you very much, Dr. Brown, and I will tell everyone on the webinar that I have given Dr. Brown full permission to tell me when there are only a couple of minutes left in my time, because I want to make sure that we have time to go on to our other presenters. So in case I'm not being kept to task time-wise, then she has kindly agreed to jump in. So I'm going to share my screen. And I am sure that someone will tell me if you are unable to see it, but I'm going to go on. So what I'm going to present about today is some research that a large team of us in Ontario did around trying to quantify what's been happening with respect to postpartum mental illness in Ontario during the pandemic. And then I'm going to finish by talking about some work that we did with the Provincial Council on Maternal Child Health to talk about some practical applications of what we might do with this information and how we can address it. There we go. And so it was, as I mentioned, it was quite a large team of individuals, some names here, which you may recognize who worked on the research study. And at the bottom of the slide, there is a reference, if anybody wants to read the whole paper, to the manuscript that we published about this. I do receive royalties from Up to Date Inc., which is an online educational initiative for authorship of materials related to depression and pregnancy. So I don't think that I have to convince this audience that the postpartum period is a high-risk time for new onset and recurrent mental illness. We know that it affects up to 1 in 5 postpartum women. And while we have less information on people who identify as other genders, maybe even greater when we take into account all postpartum people. What are we talking about? We're talking about not just the quote unquote postpartum depression, but we're talking about the fact that really any mental health issue can happen around this time. So we're talking about depression, anxiety, more severe mental illnesses, as well as addictions that can result in substantial suffering and diminished functioning for the mother and the parent, and is also linked to issues related to the child's development across the lifespan. And especially when it's not treated, it can be chronic and recurrent. So the impacts can extend far beyond the postpartum period to the entire family and across generations. So it's quite unbelievable to say that we are now almost 2 years since the WHO announced the COVID-19 as a global pandemic. But I thought I would still situate this discussion in terms of the fact that, people have been certainly anxious about contracting COVID itself, but also the containment efforts that we've all been living through, including physical distancing, travel, work limitations, et cetera, have really caused broad social and financial disruption. And no doubt there has been a mental health toll. But the question is, why speak about the postpartum population specifically, or why look at them specifically? Is that, along with all of the reasons why this is perhaps a high risk period anyway, the pandemic containment efforts really have increased social isolation, which is a major risk factor for many postpartum mental disorders, and reduced social support, which is one of the biggest factors. We talk about, the grandparent treatment, that it takes a village. The issue is that the village has really not been able or allowed for much of this pandemic to help. And then in addition to that, as everyone knows here, there also have been various disruptions in some of the support services that we use to mitigate risk for perinatal mental health issues. When other community supports are unavailable, such as public health nursing, lactation clinics, community postpartum support groups. And some of this has been, due to redeployments elsewhere. Some of it has been due to, concern about home visits. So it's been really rather complicated and for an extended period of time. So we knew already that from prior pandemics that postpartum women probably are disproportionately vulnerable to mental health effects of pandemics. But when we did this research, we didn't know much about what was happening with COVID yet. So early reports from China had suggested that women might be more susceptible to severe mental health outcomes during the COVID-19 pandemic than men, although many of the early women in those studies were nurses on the front line. Disproportionately women were nurses, for example. There was a survey that came out of Alberta in March, April of 2020 of pregnant women that showed very, very high levels of people experiencing significant distress. And then there were stories in the media, I would see them all the time, with about new mothers struggling during the COVID pandemic. And so there started to be, all sorts of different research that came out from us, from places across the world, but we really didn't have a sense yet what was happening necessarily in Ontario. And so one of the opportunities that we have in Ontario, because we're a universal healthcare system, and so there's a centralized way that the data are gathered in terms of utilization in our health system, is that we had an opportunity maybe not necessarily to track people's symptoms, but certainly to track the care that they received or were trying to receive to see whether there might be increased demand for service. So what we did was we said, okay, well, the state of emergency was declared in Ontario, March 17th of 2020. So we looked back and we took the time from January 2016 to February 2020, and we considered that pre-pandemic time. And then we considered March 2020 as the first pandemic month. And what we did was we essentially took all of the individuals who had given birth to a baby between 0 and a year, 0 days and 365 days, before the month that we were looking at. And we looked at what were the visit rates like for postpartum mental illness and addiction using all of that pre-pandemic time. And we used that to predict, in the absence of the pandemic, what would we have expected for March to November 2020? And then we looked at, visits for mental health issues to primary care providers and to psychiatrists, and altogether for mental health issues, for substance use disorders, and then we broke that apart. And so there were close to 140,000 people who were in each monthly analysis that we looked at. And in general, what you're seeing here is, who are we looking at? So the average maternal age, about 31 years old, about 45% were pregnant with their first baby. At any one time, about a third of the people who we were looking at were in their first 3 months postpartum. Over 20% were living in low-income neighborhoods. We had some information on ethnicity, but really only, I think, using an algorithm for surnames that is really, it's not perfect, but it does identify some people, and it identifies whether people are living in areas of higher or lower ethnic diversity. As some of you may know, there's actually evidence to suggest that when people are living in communities, they may actually have lower risk of postpartum mental health problems, although the isolation might have worked against that. And about 5% of people were living in the north. So what did we see? So on this graph that you see this, these blue dots and this blue line and then the red line. And what that is, that's the blue dots are the actual visit rates from January 2016 up until March 2020. And the blue lines are just the trends that we see. So it goes up a little, up and down. It's not the same every month. And the red dotted lines are the margin of error that we would expect. Then what we did was that green line is that March 2020 time period. And the black squares are the visit rates that actually happened. And so when you look at those black squares for March, April, May, June, all the way to November 2020, and you compare that to the blue line and even the red line, which is the margin of error, what you can see there is that the actual number of visit rates that were happening during the pandemic were much, much higher than what we would have expected based on 4 years of pre-pandemic data. So in March itself, and remember, we only had about half the month, we were talking about an 8% increase, but then thereafter, a 20 to 30% increase in postpartum mental health issue visits. In this graph, this picture, if I showed you the one that was for visits to primary care providers or for visits to psychiatry, the patterns really looked almost exactly the same. What we also saw, which was interesting, was that, of course, there was also the really big jump in virtual care. So, before the pandemic, only about 3% of visits were delivered virtually. And then in the pandemic, we saw very high rates of this care to these physicians was delivered virtually by telephone and by video. In some respects, and from psychiatrists, you can see it was up over 90% at one point. And so it is important to remember that some of what we were seeing might have been that we actually just saw, people more able to access care as much as we might have seen increased demand. But regardless, we just saw a 30% increase in the number of visits is really large. what were these visits for? Mainly what you see here, anything you see that doesn't overlap with and is to the right of the dotted vertical line essentially means that in that month, the visit rate for that kind of diagnosis was higher than what we would have expected. So for anxiety and related disorders and for depressive disorders, we saw much, which was the bulk of the visits generally, we saw much higher than expected. And also when we looked at substance use, although there were a fewer number of overall visits, again, even more visits for substance and alcohol use problems. And, although we didn't see quite the same pattern for bipolar and psychotic disorders, what you can see is that we did see evidence of some elevation in visit rates at some time points. And so who had the visit rates that were increased? Here, what you can see, the red dots is what we saw and the blue dots is what we expected to see. And the top panel is people in their first 3 months postpartum. And the bottom panel is people in the rest of the postpartum, so from months 3 to 12. And what you can see is that although both of them had significant elevations, the red dot is not overlapping with the blue for the most part, we did see people in their first 3 months postpartum really had kind of the biggest elevations. And then we could also see that people in the middle section of this slide, when you look at people in Q1, meaning the lowest income areas, you don't see as much separation between the blue and the red dots as you do for people living in higher income areas, which is a bit odd because we would think that people who were lower income might have been more affected. And you see a similar issue for smaller elevations and elevations that occurred later in the pandemic for people with individuals with South Asian and Chinese surnames. And so the question is why would it, why would the timing really matter? This might have been an access issue that maybe there were certain people who it was easier for them to get care, and then other people who it was maybe less easy for them to get care. And just to show you by region, what we see here in this graph is, I'm just showing you how we mapped it out, but basically the darker the colors, the more, the greater the separation between what we observed and what was expected. And so you can see in March, we're still in sort of lighter colors. And then as you move into April, we're starting to see the big separations already right away. And in the north, we saw big separations, although in August 2020, when I think if people remember, things got a little bit better up north and they actually had fewer restrictions, you can see a bit of a lesser separation between the blue and the red, whereas in the south public health units, you saw a huge separation, which is, we don't know for sure what this means, but you do wonder whether maybe some of the isolation was lessened a little bit in the northern public health regions during that time because the restrictions weren't as clear. So I hope that it was okay to present to all of you, what we did in this research study. And listen, research is truly never perfect, but I think, when you look at these data all in all, what we saw, I think, was that, anxiety, depression, substance use, at least the need for service seemed to be higher than we would have expected based on the pre-pandemic health patterns. And so to confirm that, what we were seeing in the media, what people were reporting in terms of their distress on surveys, to see that so consistently on the population level, I think, really did help us to convince ourselves, to convince policymakers and others that this is a real issue that we needed to attend to, because that the kind of increased demand for service isn't necessarily something that's sustainable if we don't plan for it. And I would say, clearly that early postpartum seemed to be a time of key need. And there did seem to be certain groups of women who might have been expected to be most impacted in terms of their mental health, but maybe weren't as able to access care, and that we needed to be attentive to that. So, it's important that we continue to monitor these trends and that we really think about, who this pandemic cohort is and what are their implications for the long term. And I think we also need to think about this virtual care because there's been such a shift that we do need to think about like who, what do we need to know in terms of access? Who is getting access? Who isn't? With all of these new virtual care modalities, is there anyone who's being left behind because maybe people don't have a private space in their homes to do virtual care, or maybe don't have access to the Wi-Fi to have a virtual care session, for example. And we also need to know more generally how some of these virtual care treatments work. And so, part of some of the work that we've done in collaboration with the Ontario Provincial Council on Maternal Child Health has been to develop a guidance document that comes along with a care pathway that is very specific to Ontario to say, okay, so if you identify somebody who needs help, what do you do with them? And so I thought I would just take a minute, some of you may be aware of this already, and I'm sure, with a public health audience, you're very aware of the Registered Nurses Association of Ontario guidelines already, and the Public Health Toolkit, which is a lot about identifying people who need help. And we wanted to take this further and say, okay, let's identify the people who might require care, but how can we be quite specific about directing them then to the care pathway that is most likely to be effective for them, depending on their level of need and their treatment preferences. And then let's also make some recommendations to remember that, just a referral isn't good enough, and make some recommendations around how do you follow people up to see, are they engaging with the services? Do they need another kind of service? And so we, if you have a look at the pathway, we have, we need to ask the people and identify them. We need to provide education and other support services. And then based on assessing the severity of the mental health concern, what treatment steps can we recommend specifically, and then arranging follow-up and making modifications to the new treatment steps. And so here's just an example. We actually said, if you use some of the scales like the GAD-7, the PHQ-9 for depression, or the Edinburgh Postnatal Depression Scale score, like what kinds of scores might lead you to looking at what kind of treatment pathways for people. And then we laid out the treatment steps, inclusive of self-help workbooks, connections to the Healthy Babies, Healthy Children program, guided self-help, all the way to how do we get people access to psychotherapies, virtually or in person, what are the resources around medications, and how do you get, specialized consultation if you need it, and then what to do in the case of an emergency. So I will stop there. Hillary has not flagged me to say that I'm out of time yet. And if people want I thought I would put the link to the PCMCH pathway there, but I could also bring it up again. I'm also happy to take questions, and I look forward to talking with you all in the panel discussion along with our next presenter. So I will stop sharing now.
Perfect timing. Thank you very much. So I'm going to introduce our second presenter. Jamie Lebois is the Regional Perinatal Mood Disorder Coordinator at Aurelia Soldiers Memorial Hospital and co-founder and research director of the Canadian Perinatal Mental Health Collaborative, a group of advocates lobbying the federal government to create a perinatal mental health strategy. Ms. Lebois holds a Master of Science in Nursing and a perinatal mental health certification from Postpartum Support International. Her work experience includes 23 years of clinical nursing, higher education, and clinical leadership positions. She collaborates at the local, provincial, and national level with multiple organizations and committees. So thank you very much, Jamie.
Thank you very much for that introduction, Hillary. I'm going to share my screen with you all. Okay, so today I'm going to be talking about the practical pieces in regards to supporting our clients and patients with perinatal mental illness during COVID-19. But I first wanted to acknowledge the enduring work of all public health nurses over the past 2 years. Being pulled from your positions during redeployment, some of you more than once, is extremely difficult, and hats off to you. So today I'm going to be discussing a case study through the lens of the perinatal mood disorder framework, which was created by Olivia Scobie, who published the Impossible Parenting book. And when we look at the biopsychosocial model, which this was built from, which is from 1977, it really helps give us a lens to understand all the different aspects that can be affecting parents as they make their journey through parenting, but also the impacts of COVID at multiple points. And we talk a lot in current media about like the biomedical domain of people in the perinatal period as it relates to health outcomes and changes in the perinatal healthcare policies. However, today I want to draw more attention to the biopsychosocial health domains and the systemic impacts of the clients that you are supporting and the clients that are struggling. And that's what we're going to be focusing on for the next 20 minutes. So I wanted to talk to you a little bit about Kelly. So this case study is loosely based on interactions from my region up in North Simcoe, Muskoka. So Kelly is a healthy baby, healthy child nurse who's been in the local health unit for over 11 years. She has a caseload of about 25 clients. Currently, it's kind of unbalanced, meaning she has a lot of severe cases, not a lot of mild to moderate. And what she's seeing with her clients during COVID is increasing symptom severity and increasing risk. And when she is doing her assessments with clients, she's having a hard time kind of discerning whether this is a perinatal mood and anxiety disorder or whether it's parental burnout. Because what we've been asking parents to do through the COVID-19 pandemic is next to impossible. And so at this point of the case study, it is December 2021, and Kelly is being redeployed for the third time. And she does a warm transfer of her client Hazel to a local specialized perinatal mood disorder coordinator. So let's talk a little bit about Hazel. So Hazel is a mom of two. She has a 6-year-old and a 10-week-old. She's new to the area and she had immigrated to Canada about 3 years ago. She has no family doctor. She has very limited supports. Her husband works evenings, and her mom was supposed to come to Canada to help her when the baby was born, but because of lockdown, she was unable to come. Hazel is doing virtual school with her 6-year-old child because now we're into January and we're into that lockdown. And when the therapist logs on to the virtual therapy session, Hazel is in bed, breastfeeding with a mask on. She's disheveled. She's exhausted. She's in tears. And she's not coping very well. It comes up during the assessment that she is COVID positive, and she is trying to mother a newborn and homeschool a 6-year-old all by herself with absolutely no supports, and she's exhausted. And after the 1-hour intake with the counselor hangs up and cries. There was nothing that she could offer this woman. She could not go into her home. She could not get a healthy baby, healthy child nurse to go into the home because of redeployment. There seemed to be nothing to offer her. And so this concept of moral systemic fatigue was kind of setting in. And this is something that in a current training I'm doing with the Canadian Perinatal Mental Health Training, they discuss as this feeling that we have when there are no options, that we can't correct a system that is failing. And when we look at perinatal mental health overall, in Canada, we do not have a federal strategy that dictates how to care, how to intervene, when to screen, and that can be very problematic. And so I wanted to, as I said, look at the perinatal mood framework by Olivia Scobie. And, talk about the fact that perinatal mood and anxiety disorders emerge from a complex set of biological, psychological, and social factors. And becoming a parent is messy, confusing, identity altering. It's accompanied by a shocking amount of adjustments for parents, including financial, hormonal, neurological, and identity changes, as well as completely different day-to-day routines. And so when we look at the biological aspect, we're looking at like the genetic makeup of a person, the huge influx and changes of hormones, and the deprivation of hormones that occur right after the placenta comes out, and we have a huge dip, and all the different brain chemicals, the changes in neurotransmitters. And all of these make people susceptible to perinatal mood and anxiety disorders. And then when we're looking at the psychological aspect, we're looking at their thinking styles and their thought patterns and their overall mental health. So parents who are more prone to negative thinking, worrying, perfectionism, rumination, or heightened critical analysis are also more prone to perinatal mood and anxiety disorders. And then looking at the individual risk factors and circumstances, this is basically anything parents consider as an added stress, trauma, or barrier to coping, such as relationship issues, breastfeeding concerns, financial concerns, and I don't know, maybe a global pandemic. And also the parental identity overall, knowing that all parents go through a process of developing their parenting identity, which can have a dramatic impact on perinatal mood. And when we look at nurse researcher Linda Clark-Amanka, she talks about the process of parental identity development that parents navigate as they are figuring out what it means for them to take on the social role of parenting and how this process contributes to the onset of perinatal mood and anxiety disorders through the following 3 stages. So the first one is role stress. This is so when parents are kind of thinking, wow, this is a little bit harder than I thought it was going to be. And parents all go through this. And parents become stressed when the vision for what they had planned doesn't come to reality. And the good news is that this is totally normal. But when we look at this through a COVID lens, we have a tremendous amount of parents that are seriously questioning what they're getting themselves into and whether they have the capacity to move forward. And then we look at role strain. So this is when parents kind of think, I don't think I'm very good at this. Essentially, parents' feelings of failure or guilt for not being able to fulfill their parenting role in a way that they had really envisioned. And that starts to accumulate and it causes them to feel down or overwhelmed or withdrawn. And some parents, they don't fall too far down this tunnel. They just readjust their expectations and they accept their limitations. But with COVID, we are seeing people falling down this tunnel and not being able to dig their way out. And this is, really, really difficult as we look at the fact that these parents are parenting the future generation and they're struggling and they don't see a way out. And then we look at the last stage of role collapse. So this is when parents actually believe that they're a failure. And this occurs when parents feel like they aren't capable of fulfilling their role as parents anymore, and they show critical or clinical symptoms of perinatal mood and anxiety disorders, and they just feel like they can't cope daily. And when they experience this collapse in their role, we really need to be wrapping around them and providing them support. But sadly, we know that not everybody gets that type of support. And that was prior to COVID-19. During COVID-19, we have seen limitations to our services like never before, and isolation, which is so very difficult. And then just the very last part of this, the culture of impossible parenting, looking at the fact that it's an imperative to analyze the relationship between the culture of parenting out there and parental mental health, because our socioeconomic family system, meaning how the families are shaped by different structures such as employment and education and childcare, the community, how this all affects these families through the perinatal mood framework. So kind of looking at the biological aspects of perinatal mental health, knowing that they're influenced by the social determinants of health, such as food and housing security, which have been threatened through COVID-19. Our thought patterns and thinking styles are influenced by our parenting role models and our access to information, such as being able to afford therapy or accessing parenting programs. And then the individual risk factors and circumstances of parents are influenced by our experiences with relational and intergenerational trauma, discrimination, and barriers to resources. And a positive parental identity is influenced by how successful we are and our community thinks we are, and at meeting the makers of good parenting. And through COVID, a lot of this has been very unattainable for parents. I wanted to talk a little bit about the biopsychosocial model, and this is in relation to the perinatal period in an article that was published by Diamond and her team in 2020. So looking at the COVID-19 pandemic, which has added a new source of stress for people in the perinatal period, and at a time when stress and anxiety are already heightened through that transition. The closures of physical mental health care spaces and the lack of support can have devastating impacts on the health of postpartum people and their newborns, and we're seeing this almost daily. The symptoms of depression and anxiety and substance use are heightened by fear of the virus, social distancing, financial effects, and other ramifications with the loss of normality and structure. So looking at the biological aspect, it's important to recognize that some physiological changes in pregnancy may mimic the symptoms of medical diseases such as shortness of breath, and physiological changes which make women more vulnerable to illness, such as changes to their immune system. And then the psychological domain, looking at the unprecedented COVID-19 pandemic, that there has been an understandable psychological crisis as this time of exacerbated uncertainty and anxiety within our healthcare system. And this is complicated by our decrease in access to mental health services and extremely long wait lists, and our limitations surrounding teletherapy. Even though it's a fantastic advancement, it is not the same as in-person care. And we cannot overlook that. Looking at the social aspect, research demonstrates a significant association between social isolation and loneliness and feelings of absence of our social network and companionship, which can be really, really difficult. Through the pandemic, many families have had a disruption or discontinuation of reproductive technology treatments. They have had reduction in their face-to-face visits and an increased use of telehealth. So coming back to how this integrates into your daily practice and how to kind of see hope through all of this challenge. So when we are supporting our perinatal mental health community, it's really important to know where you are. Know the community and the supports around you. So when you are supporting your clients, we can wrap around them and give them fulsome care. So looking at the different parenting programs and local groups in your community, so our early on child and family centers, our mother care and next step programs, which might be CPMP or CAPC in your area, library programs, pregnancy resource centers, and this is going to come up in a little bit, and our Healthy Baby, Healthy Child program. And then looking at specialized therapists in your area. It's hard to keep track who has the training, but when we are looking at therapy for this patient population or client population, it's very important that we are seeking out people that are specialized in perinatal mental health so that our clients are being validated and reassured. And if you don't know who's in your community, you can go to Postpartum Support International. I put a hyperlink to the provider page, and you can type in where you are, and it brings up all the people who are specialized in perinatal mental health and talks about their credentials. And you can also look, are these people covered? Are their services covered by OHIP? Do they provide a sliding scale? Many private therapists will have a small amount of their practice where they will do sliding scale or decreased service fee. And then look at what the wait lists are. And as I said, through the pandemic, most therapy wait lists are quite long. And then also, when you're thinking of referring, what is the reputation and review of that therapist? Is it positive? Do you know them? Have you heard things about this therapist? Because I really strongly believe that we should have an idea of who we're referring to. And then something that is not very clear all the time is the difference between different clinicians. What's the difference between a psychotherapist, a psychologist, a social worker, and a psychiatrist? So understanding who can diagnose, who can prescribe medication, and who can do different modalities of therapy. And when programs aren't being done in person, looking at what is available virtually. So Postpartum Support International has fantastic programming that's available all the time. And we can access virtual support groups. We can chat with an expert, and then they have specialized coordinators. So if you have somebody that experienced birth trauma or had a near miss situation, there are specialized coordinators for that. And their support groups, they have so many now. So there's groups for people that have experienced loss, people who have had a baby in the NICU, have a child that's medically fragile, and all of that. And then looking at the specialized perinatal mental health programs. Unfortunately, these do not exist in smaller, more rural areas, but many of them do have a virtual component. So looking at Simone's program at Women's College Hospital, the Reproductive Life Stages program, the Mount Sinai Perinatal Mental Health program, which has the virtual component, and Sunnybrook has the Reproductive Transitions Clinic. Ontario Shores has the Women's Clinic, St. Joseph's Women's Health Concerns Clinic. Where I am at OSMH, it's a program of one, but that is also an option. And then Health Sciences North in Sudbury also has a perinatal mental health program. So looking at the recommendations for care, we have gone almost totally online. And as I say this, things are opening up. More things are becoming in person again, and that brings hope. And that is a fantastic thing. And a lot of these virtual options were long overdue. We should have been doing them before, and now it gives an option, and which can be really helpful for perinatal families that find it difficult to pack the baby up and get somewhere in person. But also being aware that these virtual programs are somewhat of an assumption of privilege, meaning that in terms of access and resources, how are our underserviced or under-resourced people accessing services? The nurses up north will tell you that there may be unstable internet and maybe not a lot of good cell coverage. And so it can be really difficult during virtual times to connect with families, especially when you're not doing in-home care. So really trying to be creative and think outside of the box. Also remembering that we might have people of low socioeconomic status, intellectual issues, and those with no internet, as we said. And we've kind of coined these as the unreachable. So how are we engaging these people? How are we providing care during these really difficult times? And, you know, that's really important for us to think outside of the box. I wanted to talk a little bit about Hazel again, because this was a situation that had never happened before. Normally we could go into somebody's home, we could provide better service, we could wrap around with different programming, but this was a time where there was actually very little we could do. And so the counselor engaged, the public health unit discussed levels of service with the HBHC manager, and we were able to engage some and HBHC nurse that was doing some phone follow-up. And we found out that this woman was hugely committed to her community and being supported by the local pregnancy resource system Pregnancy Resource Center, which was a Christian-based organization, which she found amazing because what she really wanted was to prioritize her prayer. And she found that very difficult to do with the six-year-old at home and while trying to exclusively breastfeed. And her congregation of her church wrapped around her and started dropping off meals and engaging in more prayer with her from her front step with a window opener, whichever. And that brought a huge sense of hope. And so when you are feeling extremely challenged, like you have nothing to offer, ride the wave. Because what was fantastic about this situation is once the COVID symptoms went away, she had a renewed sense of hope herself. The next session with her counselor, she was smiling, her mask was off, she felt connected to her community. And from her point of view, we wrapped around her and provided her outstanding care. But, you know, when you're providing service through a pandemic, when people rely on you, that can be really difficult. So just looking at some tips and tricks for you as you continue to work through this is, you know, helping our clients understand that there is restrictions that is set from above, and then the prioritization of our clients' mental health. And sometimes we have to increase our bubble. We have to prioritize mental health and allow people to come in to help support in a meaningful and ethical way that makes sense for the family. And then doing a little what we call distress tolerance or radical acceptance with our clients, with kind of the vision of it is what it is. We can't change it. We're going to work within the current system. We're going to support our clients through this uncertainty and tolerating it a bit, because a lot of our clients, that health anxiety that came with being pregnant through a pandemic and not knowing, should I take a vaccine, should I not, was, you know, really, really difficult. And being able to teach them to sit with that uncertainty a little bit was so very important. And then meeting them where they're at. And this was what a public health nurse said to me the other day, is when we're going through, you know, such tough times with our clients, sometimes we have to step off our, you know, professional soapbox and support our clients like the moms that we are, and really get down and meet them where they're at and help them see past, you know, what's occurring right now. So a little threading in tenets of cognitive behavioral therapy or dialectical behavioral therapy, mindfulness, and yoga. So in conclusion, in summary, looking at the biopsychosocial model and the aspects of parenting is really complex, and mental health is complex. But when we work to understand all the intricate details, it dramatically affects the support that parents get when they reach out for help. Thank you so much. And I have included my contact details.
Thanks so much, Jamie. So we have about 10 minutes for questions, and I see there are already some questions in the Q&A. So if you do have questions, please put them in the Q&A box, and we'll get to as many as we can. And I'll start off with the ones that I can see. So the first question is for Dr. Vigod. And the question is, were there differences in what you observed among those who use substances versus those with mental health concerns?
So I think I did have one slide there where the increases in visit rates were increased both for alcohol and substance use disorders as well as for depressive and anxiety disorders. Certainly what we have to remember is those were increased numbers of visits for substance and alcohol use disorders. So that means it won't count people who who were using or who might have been, developing a disorder but didn't require treatment. There have been, though, multiple surveys now, and the CAMH Monitor survey actually asks people about drinking and whether they think that they're drinking more than than they should be or otherwise. And they split it up. You can go to their website, it's interactive, and they can split it up actually by whether people identify as parents or not. And you can see that among the people who identify as parents, there is sort of an increased number of people who are reporting that they're doing things like binge drinking, for example. So I think in answer to that question, we're seeing increases in issues all across the board, right? And I think the way I would conceptualize it is, if people kind of had a propensity for their reaction to be a mood disorder or anxiety disorder or substance use disorder, what we're just seeing is there's more stress. And so whatever they might have had a propensity to develop, they're probably more likely to be struggling with it. And that doesn't, we didn't look in our study, for example, at comorbidities, but of course, sometimes these things go together, right?
Absolutely. And another quick question for Dr. Vigod, just related to the geography piece. How did you define the North? Was there a specific boundary that was used?
Yeah, so the North, I'm going to misremember now whether it's I think it's the 5 Northern Public Health units that are defined as such, by Statistics Canada. Jamie's nodding. I think that's right. I just can't remember whether it's 5 or 6, but it's specifically the way that it's defined by kind of the Canadian geographical system. And so what we have to remember is that a very small proportion of the population are living there, but it's a very large area. And there are definitely big differences in terms of access to specialized care in those Northern Public Health units.
Yeah, and I think that feeds well into the next question as well. And maybe, Jamie, this might be something you want to weigh in on. Is there perinatal mental health supports other than online supports in HPHC in Northwestern Ontario that mothers can access in-person supports, for example? So just a question about what's available in those areas.
So Northwestern, we're looking at like the Thunder Bay and Sault Ste. Marie areas. It's interesting through the pandemic because I'm a volunteer coordinator for PSI. I was contacted about services in areas of the country that I've never been to. But, when we are looking at perinatal mental health supports for families in these locations, really looking at the public health programs there. Do they have their own support groups that they are running, really pulling in the community agencies that are supporting our 0 to 6 populations, and if there isn't the online option, it can be really, really challenging. So look also at the academic institutions in those areas too, because the people doing research there are highly connected to the different services also. So always feel free to connect with Postpartum Support International, because they do have coordinators in different regions throughout Canada. So I do North Simcoe Muskoka, and there are more northern coordinators that can help get you connected or get your clients connected.
Great, thank you. And it looks like they're interested specifically in Kenora and Dryden, closer to Winnipeg. So perhaps check out that resource that Jamie mentioned. Great. Okay, I'm just going to jump over to a question that's been in the chat for a little while, and then I'll jump back to the Q&A. So the question in the chat is, the EPDS is not considered a validated tool for many languages. This is often challenging when working with diverse populations who do not have English as their first language. Any suggestions or supports for this population? So do either of you want to take this question?
The one thing also, BC Perinatal Services has the EPDS translated in more than 30 languages on their website. So it is important that we are using those translated tools with our client, because the language of the EPDS isn't actually translatable in different cultures. So making sure that you have those tools and using translation services through your institutions is really important.
Great. And Simone, did you want to add anything to that?
I think I would just say that the EPDS has been translated into and validated in like over 50 languages. So, you know, I would say, I think it's like, as we said, like it can be used with diverse populations. I think the other thing to remember is always to rely on our own clinical acumen. Like, the truth of the matter is that in studies that have been done with what they call the Woolley questions, which is essentially, are you feeling, you know, down, sad, or uninterested in things, and do you want some help? That actually performs just as well as any of these screening questionnaires in terms of identifying people who might need help. And so I always say the most important thing is to be, you know, to have some cultural humility around, you know, what different kinds of distress, you know, look like, and to really, you know, that we should never be saying to someone, oh, you scored too low on that, you know, scale, therefore you don't need help, right? That just simply wouldn't be logical. And so while these tools can be helpful, I would venture so far as to say that they're not absolutely necessary, and they don't trump clinical care. Like, even in the pathway from the PCNCH that we showed, those are suggestions, right? And those are guidances, but they are not, it's not absolute. Like, this isn't a blood test and, you know, you're treating like a blood glucose level with insulin, right? Like, you have to bring in, you know, like the clinical does trump all.
That's a great point. And there's a couple of questions asking for the resource with the translated EPDS. And I think, Jamie, you might have put something in the chat for that. So we have about 2 minutes left. Maybe we'll end on one last question, which I think is a great one to end on. There's a comment regarding how difficult this has been for healthcare providers, that it's been very emotional navigating the needs of mothers during this time. So the question is, what can we do as care providers during COVID to come together to debrief and validate one another's experience during this time? So if either of you want to take that question, that'd be great.
We're both pausing. I think it's really important to remember that you are providing team-based care a lot of the time. So debriefs and consultations with your team, whether that's in person or virtual, or using services, Canadian Perinatal Mental Health Training has consultation with their training, and through our region of North Simcoe Muskoka, we are providing some training and consultation right now, and it's hugely supportive. So having that option might be something that you discuss with your managers, but making sure that you have open communication and leaning on each other and discussing those cases, because it is extremely heavy doing support and therapy through a pandemic. So also taking time for you to refill your cup and doing your self-care and prioritizing yourself, because you can't be everything to all of your clients.
Great. Thank you so much, Jamie. We're at 1 o'clock, so I'll turn it over to Cassidy, and thank you everyone so much. Thank you to our presenters and the audience for your questions. This has been a fantastic session, so thank you.
Yes, this concludes our webinar for today. We hope that you enjoyed the presentation. On behalf of our speakers and our team at OPHA, we would like to thank you for joining us this afternoon. You should be receiving an email shortly with a link to the survey asking you to provide feedback on today's presentation. All responses are anonymous, and your suggestions help us improve our webinar programming. Thank you again to our speakers and to everyone for joining. Have a good rest of your day.